Picture this for a second. You experience this sudden urinary leakage, or maybe a frantic, just agonizingly burning urgency to find a restroom.
Right, which is terrifying.
It is. So you do the right thing. You go to the doctor, they run the standard tests, but your tests come back perfectly clear. I mean, no infection, no obvious anatomical failure.
Which leaves you completely in the dark.
Exactly. Because, well, usually medicine feels a lot like engineering, right? You break your arm, a jagged white line shows up on an x-ray, and the doctor points right at it.
Yeah, it's visible. It's comforting in a weird way.
Right. But in the world of pelvic health and urology, that x-ray machine is often just broken. You are simply told that you have to live with it, or worse, you're recommended a major surgery that, years down the line doesn't actually fix your problem at all.
And that invisible, just murky diagnostic landscape is a daily reality for millions of people, particularly women, actually. And the frustration really comes from treating the human body as a collection of static pipes rather than a highly dynamic system.
Which brings us directly to our mission for this deep dive. Today, we are sorting through a pretty massive stack of clinical guidelines, urology clinic resources, and medical research to investigate a truly fascinating medical mystery.
It really is a mystery.
It is. We are asking a highly specific question today. Can chronic, low-grade inflammation in the urethra cause these invisible microspasms, which is officially known as urethral instability, that is routinely mistaken for severe stress incontinence or chronic UTIs?
To even begin answering that, we have to establish a foundational truth that often gets glossed over in standard clinical settings. The urethra is not just a passive pipe draining a tank.
Right, it's not just plumbing.
Exactly.
Yeah.
It is an incredibly complex, highly dynamic structure. It's lined with a specialized mucosal tissue. It's surrounded by an intricate network of muscles, and it is wired with highly sensitive reactive nerves. So when that complex structure misfires, the resulting symptoms completely mimic a failing bladder or, a mechanically broken pelvic floor.
Okay, so let's unpack this. To understand how invisible microspasms can totally fool a trained physician into diagnosing severe incontinence, we first have to understand what is actually irritating the urethra in the first place, right?
Right.
Because in the clinical literature we're looking at, this initial irritation is often called urethral syndrome, or sometimes symptomatic abacteriuria. And the sheer numbers on this are staggering.
Oh, they're massive.
Yeah. This syndrome affects up to 40% of individuals who present to a clinic with chronic urinary symptoms.
And the presentation is precisely what makes it so deceptive, The symptoms perfectly mirror a classic urinary tract infection. The patient experiences intense burning during urination, this immense heavy pressure in the lower abdomen, and a frequent urgent need to go.
So they give a urine sample totally expecting to be handed a prescription for antibiotics.
Exactly. But the repeated urine cultures come back completely negative. Zero bacteria.
Which, that leaves the patient feeling like they're literally losing their mind. They were in agonizing pain. But the lab results declare they're perfectly healthy.
Because the lab is looking for an infection, right, when the actual culprit is inflammation.
Oh, wow. Okay.
Yeah, and the triggers for this inflammation are incredibly varied. They're often deeply integrated into everyday life. So we're looking at chemical irritants, things like scented soaps, bubble baths, spermicides, or the dyes used in feminine hygiene products.
Just everyday stuff.
Exactly. And then there's physical trauma. This could be the tissue strain from childbirth, the repeated friction from medical catheters, or even just frequent bike riding or rough sexual intercourse.
Wait, you mentioned earlier this overwhelmingly affects women, women between the ages of 30 and 50. That timeline screams hormonal shift to me. Is the onset of perimenopause or menopause actively triggering this inflammation?
That is a brilliant deduction, actually. Yes, it's a very significant component. A natural drop in estrogen causes profound changes on a cellular level. Well, estrogen is essentially the fuel that keeps the mucosal tissues of the vulva and the urethral lining thick, plump, and resilient. It encourages rapid cell turnover and helps produce glycogen, which, supports a healthy local microbiome.
So without it, things just break down.
Right. Without that constant supply of estrogen, the urethral lining literally thins out. It loses its elasticity and its protective barrier, so it becomes highly susceptible to everyday friction and irritation.
It makes me think of a car's check engine light flashing. The driver takes the car to the mechanic. The mechanic keeps checking the main engine, which, in this anatomical scenario is the bladder, and says, hey, the engine is completely fine.
I love that analogy.
Thanks. But the actual problem isn't the engine at all, right? The problem is a frayed, inflamed wire right there in the sensor, which is the urethra. The warning signal itself is structurally damaged.
Yes. And what's fascinating here is how that damaged sensor functions on a microscopic level. The literature explains this through what they call the leaky epithelium theory.
Leaky epithelium. Okay.
Yeah, so the epithelium is that protective inner lining of the urethra. It's coated in a thin layer of protective molecules meant to keep the harsh chemicals in your urine from penetrating the tissue.
Like a waterproof coating.
Exactly. But when that lining becomes dysfunctional due to chemical irritants, physical trauma, or that lack of estrogen we just discussed, it loses its barrier function.
Mm.
It becomes highly permeable or leaky. And this allows the normal acids and salts present in your urine to just seep deep into the underlying submucosal tissue.
Oh, man. That sounds like pouring lemon juice directly onto an open rug burn every single time you go to the bathroom.
It is intensely painful, and it creates this localized state of chronic, low-grade abacterial inflammation. If that inflammation is left unchecked over months or years, the body, it tries to heal the constant damage.
Which makes sense.
Right, but that eventually leads to fibrosis, microscopic scarring. And this scarring traps and irritates the local nerve endings, resulting in profound nerve hypersensitivity.
So the nerves are just constantly freaking out.
Exactly. The nerves in the urethra are effectively placed on high alert, screaming a warning signal 24 hours a day.
Okay, so the tissue is leaky, the nerves are on fire, and the check engine light is flashing. But, burning pain is one thing. I'm still stuck on how a localized rug burn in your urethra translates into a sudden physical gush of urine. Pain makes sense to me, but a sudden structural failure just from inflammation.
And this is where we introduce a concept that remains incredibly under-recognized in everyday clinical practice, despite being thoroughly documented in urodynamic research. It's called urethral instability, or URI.
URI, got it.
The International Continence Society has a very specific operational definition for this. They define it as an involuntary fall in urethral pressure in the absence of a bladder contraction.
Wait, so the bladder, the primary engine, isn't squeezing at all to push urine out? The urethra is just randomly falling completely open.
Unprovoked and spontaneously, yes.
That is wild.
It is. If you look at the complex urodynamic graphs from researchers studying this phenomenon, you see the resting pressure of a healthy urethra as a relatively stable, flat line. It's doing its job, maintaining a tight, high-pressure seal against the bladder.
Right, holding the door shut.
But in a patient suffering from urethral instability, you observed spontaneous, wild, jagged fluctuations in that resting pressure. The pressure is bouncing up and down chaotically on the graph, and if the pressure suddenly drops to zero during one of those wild fluctuations...
The door just swings wide open.
Exactly. The physical seal is temporarily broken, and urine simply leaks out onto the patient's clothes.
Wait, I need to push back on this for a second, because we've been calling these microspasms. But if a muscle is spasming, shouldn't it be squeezing tightly shut? A spasm implies tightening, like a sudden Charlie horse in your calf muscle. Why would a spasm in the urethra cause it to fall open and leak?
That contradiction is exactly why this condition confuses so many people, including highly trained urologists. We really need to completely redefine what a spasm means in this very specific context.
Right.
We aren't talking about a simple muscle clenching tight. We are talking about severe neuromuscular chaos.
Neuromuscular chaos. I really like that description.
It's accurate. Detailed animal studies have revealed something remarkable happening at the nerve level. Researchers discovered this novel urethra-to-urethra reflex that is directly triggered by chemical stimulation.
The lemon juice on the rug burn.
Precisely. Specifically, the exact chemical irritation from that leaky epithelium we just discussed. When the nerves embedded in that damaged lining become irritated by the acids in the urine, they misfire.
So they're sending the wrong signal entirely.
Right. Instead of sending a steady, rhythmic signal to the smooth muscle to stay closed, the chaotic nerve signals trigger a sudden release of local neurotransmitters that cause the urethra to rapidly and completely relax its closing pressure when it absolutely shouldn't. It is essentially a biological short circuit. The spasm isn't a tight squeeze. The spasm is a sudden, chaotic failure of the muscle tone that completely destroys the anatomical seal.
Wow. Okay, so it isn't a mechanical weakness like a loose hinge on a door. It is a localized panic attack in the nerves of the urethra that causes it to just drop its defenses entirely.
Yes. And to make matters even more complicated, the surrounding muscles try to fight this internal panic attack. We see this phenomenon called external sphincter spasticity.
Wait, what does that mean?
Well, the larger pelvic floor muscles surrounding the urethra, they sense that the internal seal is failing. They sense that there is localized inflammation and instability, so they spasm defensively. They clench up tightly to try and stop the impending leak.
Which sounds like the body's doing exactly what it's supposed to do to protect you, right?
You would think so, but as a compensatory reflex, it is actually disastrous over time. It ingrains a terrible voiding habit.
Oh, because they forget how to stop clenching.
Exactly. When the person actually sits down on the toilet and tries to pee normally, those pelvic floor muscles are so used to being clenched in a defensive guarding state that they literally forget how to relax. This causes a staccato, stop and start urine flow, and often incomplete emptying of the bladder.
Which just breeds more irritation and potential bacterial growth. It's a vicious cycle.
It really is.
Okay, here's where it gets really interesting and, honestly, highly alarming for anyone currently navigating the healthcare system with these exact symptoms. Because this sudden loss of pressure causes visible leakage during the day, maybe when you stand up, shift your weight, or move around, it looks identically from the outside to classical severe stress incontinence.
Yes, the presentation is functionally identical.
And this is where patients get trapped in devastatingly wrong treatment plans.
It is a profound misdiagnosis trap. To understand why standard tests completely miss this, we have to look deeply into how normal stress urinary incontinence, or SUI, is routinely diagnosed in a clinic. Classical SUI is almost exclusively categorized by structural mechanical failures.
Right, the actual plumbing issues, not the electrical wiring.
Exactly. The two main clinical categories are urethral hypermobility and intrinsic sphincter deficiency, commonly called ISD.
Okay, so break those down for us.
Sure. So in hypermobility, the supportive pelvic floor hammock has dropped. This is often due to the physical strain of childbirth or the tissue changes of aging. Because of this drop, the urethra lacks a firm physical backboard to compress against when a sudden force, like a cough or a sneeze, hits the abdomen.
Got it. And ISD.
In ISD, the sphincter muscle itself is permanently and inherently weak. The urethra is essentially functioning as a fixed, open lead pipe.
And doctors have very specific standardized metrics to diagnose these structural failures, right? According to the urology guidelines in our sources, during urodynamic testing, they look for a maximum urethral closure pressure, the MUCP, or they look for a Valsalva leak point pressure, the VLPP.
That's right.
These sound incredibly dense. Let's translate these out of medical jargon. What do these numbers actually represent for the patient just sitting in the exam chair?
Think of the maximum urethral closure pressure, or MUCP, as a literal measure of strength. They measure the pressure in units called the centimeters of water. Imagine a literal physical tube of water pressing down on the sphincter.
Okay, visualizing a tube of water.
If your sphincter muscle cannot generate enough squeeze to hold back a mere 20-centimeter column of water, the guidelines state your muscle is inherently, permanently weak. You are diagnosed with ISD.
Okay, that makes sense. And the Valsalva leak point pressure.
Well, a Valsalva maneuver is simply the act of bearing down, mimicking the exact downward physical force of a heavy cough or a laugh. So the doctor measures how much downward pressure it takes to force urine past the seal.
And what's the threshold there?
If it takes very little pressure, specifically under 60 centimeters of water, to force a leak, again, you are diagnosed with a mechanically failing sphincter.
Okay, so if your static numbers hit those specific low thresholds, boom, you are slotted into the anatomical plumbing failure category. But applying that to what we just learned about urethral instability, I see a massive flaw in relying solely on those static pressure numbers.
It's a huge flaw.
Because if a patient is suffering from inflammatory microspasms, their urethral pressure is crashing dynamically, right? It's a moving target.
That is the crux of the entire diagnostic failure. A patient with urethral instability might have a perfectly strong sphincter muscle. Their baseline MUCP might be well above 20.
So they pass the strength test.
Easily. But because standard urodynamic tests often just take a brief snapshot of the urethra's pressure, or they average the numbers out over a few seconds, they completely miss the spontaneous wild crashes to zero. Furthermore, these tests are heavily weighted toward observing the detrusor, the main bladder muscle, looking for overactivity there.
They are quite simply looking at the wrong engine part. So what does this all mean for the patient seeking help? Why is this distinction between a static plumbing failure and dynamic neuromuscular chaos so crucial for the person sitting in the doctor's office?
Because it completely dictates the treatment, and getting the treatment wrong carries incredibly heavy consequences. If a doctor looks at a snapshot test, mistakenly believes your leakage is due to anatomical SUI, like a permanently weak sphincter, the accepted standard of care is to prescribe surgery.
Surgery, right out of the gate.
Yes. They will highly recommend implanting a mid-urethral sling, a pubovaginal fascial sling, or they'll inject synthetic bulking agents directly into the urethral walls.
So they are going in to forcefully fix the plumbing. They are building a physical synthetic backboard for the urethra to rest on, or, literally bulking up the walls of the pipe to force it closed.
Yes. But if the true root cause of the sudden leakage is inflammatory microspasms, if the fundamental problem is the frayed electrical wiring, not the plumbing, a physical surgical sling will do absolutely nothing to fix those misfiring nerve reflexes.
Because you can't fix a nerve with a piece of mesh.
You really can't. In fact, if we think back to the core trigger, putting a synthetic mesh sling or wrapping a tight fascial sling right up against an already inflamed, irritated, microscopically scarred urethra.
Oh no, you are just introducing more physical trauma. You are adding massive fuel to the inflammatory fire.
Exactly. It creates a nightmare scenario for the patient. The surgery exacerbates the underlying pelvic floor tension, it massively increases the local inflammation, and it leaves the patient dealing with all of their original unpredictable leakage, plus brand new chronic pelvic pain, and voiding dysfunction from a major invasive surgery they never anatomically needed in the first place.
That is staggering.
Yeah.
It is just a terrifying reality for anyone blindly trusting the standard diagnostic pathway. You go in hoping for a cure and come out with a permanently compounded problem.
Unfortunately, it happens far too often.
So, if standard snapshot incontinence tests completely miss these dynamic microspasms and standard structural surgeries make the problem worse, how do we actually solve this puzzle? I mean, how do doctors correctly identify and treat this condition?
The absolute gold standard for catching urethral instability is a highly specialized, comprehensive test called Video Urodynamic Studies, or VUDS, combined with continuous urethral pressure profilometry.
Continuous being the operative word there, right?
Right.
Not a snapshot.
Correct. Very importantly, continuous. During a VUDS test, specialized sensor catheters are used to measure the internal pressure of both the bladder and the urethra simultaneously and continuously over an extended period. At the exact same time, the physician is watching the anatomy function in real time using continuous fluoroscopy, which is basically an X-ray video. That combination is the only way to physically witness the urethra's pressure chaotically crashing to zero, allowing the contrast dye to leak out, all while verifying that the bladder muscle itself is remaining completely quiet and unprovoked.
Okay, so let's say a patient advocates for themselves. They demand the correct continuous test. They get the VUDS, and the doctor watches the monitor and says, aha, it's not a mechanically weak sphincter at all. It's dynamic urethral instability. We caught the microspasms on tape. What happens next? I assume the treatment plan must look completely different.
Oh, it requires a drastic pivot away from the operating room. Once the physician accurately identifies this as an inflammatory and spasmodic nerve issue, the treatment focuses entirely on addressing the physiological root causes. First, you must remove the initial triggers.
So back to the basics.
Yep. You ruthlessly eliminate chemical irritants. No more scented soaps, no bubble baths, no irritating hygiene dyes.
You essentially give that leaky, damaged epithelium a chance to physically patch its own barrier.
Exactly. Second, if the patient falls into that perimenopausal or postmenopausal demographic we highlighted earlier, topical vaginal estrogen is heavily utilized.
To build the tissue back up.
Right. Applying localized estrogen directly to the tissues rapidly encourages cellular regeneration. It rebuilds the mucosal layers, thickens the tissue back up, and effectively restores that protective barrier against the acidic urine.
Okay, so we're fixing the frayed wire.
Mm-hmm.
But what about the panic response that's already hardwired in? How do you quiet the neuromuscular chaos that's causing the sudden drops in pressure?
That requires pharmacological intervention. Doctors will prescribe specific medications like alpha blockers or targeted antispasmodics. To tie it back to your check engine light metaphor, these drugs act like a software reset for the nervous system.
A software reset, I like that.
Yeah, alpha blockers specifically bind to the nerve receptors in the smooth muscle of the lower urinary tract, blocking the specific neurotransmitters like norepinephrine that are sending those chaotic, short-circuiting panic signals. It chemically forces the internal sphincter muscle to maintain a steady resting tone rather than wildly fluctuating.
Okay, so the tissue is healing, the internal nerve panic is chemically blocked. What about the larger pelvic floor muscles that are still locked in that defensive guarding state we talked about?
That is where targeted pelvic floor physical therapy becomes essential. Now, when most people hear pelvic floor physical therapy for urinary leakage, they immediately think of Kegel exercises.
Right. Everyone says, do your Kegels. They assume they need to aggressively squeeze and strengthen a weak muscle.
Which, based on everything we've just discussed, sounds like the exact opposite of what a patient with urethral syndrome actually needs.
Because their muscles are already completely exhausted from clenching.
It is the exact opposite, yes. Remember that external sphincter spasticity? The pelvic floor is locked in a chronic defensive spasm. So a highly specialized physical therapist will work with the patient to downtrain those muscles.
Downtrain, meaning teaching them to let go.
Exactly. Through biofeedback and manual therapy, they physically teach the nervous system how to relax the pelvic floor, how to let go of that deeply ingrained tension. Unclenching that defensive guarding dramatically relieves the physical pressure and friction on the inflamed urethra, allowing the whole system to finally reset.
That makes total logical sense. It is entirely about unlearning the body's deeply ingrained panic response.
And for the most severe refractory cases, where the nerves have sustained such profound microscopic scarring that they are completely unresponsive to localized medication, or physical therapy urologists might look at advanced neuromodulation.
What does that involve?
This involves using gentle, targeted electrical impulses to physically alter and reset the nerve pathways traveling from the spine to the bladder and urethra. But notice the overarching theme here. The clinical focus remains entirely on healing the nervous system and restoring tissue health, never on anatomical suspension.
Never on the plumbing. It all comes back to diagnosing and treating the wiring. This has been a truly eye-opening deep dive. To summarize the journey for everyone listening, if you or someone you care about is dealing with unexplained, sudden urinary leakage, severe urgency or chronic burning pain, and the standard snapshot tests are coming back entirely normal, the answer might not be a failing engine or a mechanically broken pipe.
It rarely is in these cases.
Right. It might be chronic, low-grade, invisible inflammation causing the urethra's internal nerve pressure to chaotically short-circuit. Demanding the right continuous tests and treating the localized inflammation and the nerve spasms, rather than just defaulting to invasive surgical slings, is the true key to finding lasting relief.
Recognizing these microspasms completely shifts the paradigm of how we view and treat these debilitating symptoms.
It really does. It lifts the fog on that murky diagnostic landscape we were trapped in at the beginning of this conversation. But before we wrap up today's deep dive, based on all these complex clinical texts and urodynamic studies we've unpacked, what is a final lingering thought we should be taking away from this?
Well, if we connect this back to the bigger picture of clinical care, this raises an incredibly important question, one that is explicitly debated within the deeper research literature. We established as a fundamental fact that direct physical trauma, including previous pelvic surgeries and the repeated insertion of stiff medical catheters, is a known primary trigger for urethral scarring and inflammation.
Right, because that friction destroys the protective epithelial barrier.
So we have to critically ask ourselves, could it be that the very medical procedures, the invasive surgeries, and the standard catheter-based diagnostic tools we routinely use to investigate and treat these common urinary issues are actually inadvertently triggering the low-grade mucosal inflammation that causes these mysterious microspasms in the first place?
Oh, wow.
Are we, in our pursuit of a plumbing fix, sometimes actively creating the very neuromuscular chaos we are desperately trying to cure?
Wow. That is a heavy, incredibly vital question for both patients seeking care and doctors providing it to keep in mind. We might literally be creating the chaos we're trying to fix. Thank you all for joining us on this deep dive. Until next time, keep asking the hard questions.